Okay. Welcome everyone to the guest lecture, the Pharmacotherapeutics for Remote Area Nurses online program. We're lucky enough to have Emeritus Professor Rick Speare here to have a little chat with us about the management of strongyloidiasis.
Thanks, Toby. I thought this talk to be relevant for working in rural and remote Aboriginal communities, because strongyloidiasis is quite an issue in those communities, but it's neglected. So to get an understanding about it. So this, look at this is what we're trying to achieve. So I'll background to understand strongyloidiasis and its management, talk about it and monitoring, and then a bit of epidemiology, and just to finish up with control programs that have actually been trialled in Indigenous communities. I'll top down inverted triangle approach. So the key to remember about this part is it's a tiny little worm and 2.5 millimeters long. Lives in, but it actually lives in the mucosa of the small intestine. Effective larvae, and that makes long, and most people are adequately treated. Clinicals are non-specific except for one, acute and chronic disease, and occasionally really severe disease that kills people. It's very high in rural and Aboriginal communities. As said, it's basically neglected.
Rick,
yeah, go on, Toby.
Can I just ask, what does that mean, autoinfective larvae?
That, but what autoinfective are larvae that form in the body and infect the person by. If you form the larvae outside the body, and then a person might get reinfected, but has to come in from outside. But with strongyloides, once you're infected with strongyloides, you never lose it, because the autoinfective larvae keep on building infection or keeping it going.
Okay.
It's a very unusual characteristic among mammal parasites.
Mm-hmm.
Makes this species quite unique.
Yeah.
So look, there's a picture of the worm from post-mortem thing. You see that the worm is 1.5 millimeters long, but it's incredibly 0.06 of a millimeter across. And even when you get these worms out of the small intestinal mucosa, they're really to see because they're so thin. The best thinking of the female of Strongyloides stercoralis, the parasitic stage, it's like a very small snake, and it moves like that. It's got a sinuous sort of movement. The thing about this worm is that there's no males, no parasitic males. There's only parasitic females, reproduced by a process called parthenogenesis. So with this worm, it does actually live in the small intestine, like hookworm and roundworm and the other worms. It actually grows in the mucosal layer. And if you look at this cross-section of the small intestine, you can see that there's a logical section line, and it's lined by mucosal cells. And see these round structures sitting in tunnels in the mucosa. And that's the parasitic worm. So, can you see my pointer there, Toe?
No, I can't.
Okay.
But
so
there's an option can't see your pointer.
Yeah, no, it's okay. If we look at that image there, it's a question of a crypt, and see on the left-hand side you can see like cells that look like a bit of border. That's the normal mucosal cells, and they go down, starting from the top. And says a layer goes down, but it's got sort of structures in it and oval structures.
If you look at the top left of your screen, is there a little pen there?
Yes.
Yes, that should enable you to annotate the slide.
Oh, okay.
Yeah. Okay. Yes.
All right. So this is normal there. This is like a leak section through a worm, and you can. This is a cross section through a cylindrical worm. You can see on the outside there's a layer of mucosal. So the worm is actually burrowing in the mucosa in a tunnel, and as it moves along, it lays eggs. And this here is a cross section through an egg. It's an interesting parasite because it actually hides from the body to some extent because it's in the tissues. Tunnels in the mucosa, and it lays eggs as it goes along, and eggs then develop and they hatch the larvae, which then escape into the lumen of the small intestine. So, and then you'll find the larva sitting out in the small intestine, and it actually goes down in the feces to us outside. And so, with other parasites, you have eggs come out in the feces and larvae are protected inside the egg. Strongyloides, these larvae come out, and that's the head end of the worm, and that's the tail end. And so, if they're trying to make a diagnosis in the laboratory, that's one of the things they're looking for, these larval stages in the feces. Here's a complicated life cycle, but if we start here, cell which is in one of those tunnels and goes through the small intestine, or actually here. So there's only a female. She doesn't mate with anything. She can just lay eggs by herself. Get laid. They're in the but then they enter the larvae, which pound through the larvae and actually come out in the feces. When you come outside, again, bizarre worm. It can be like hookworm, and that larvae can go directly to infective larvae. This one here, which can be like hookworm. It can detect the presence of humans and actually burrow through blood, go through the lungs, go to the mouth, and get swallowed, and actually come back down to the small intestine. That's one life cycle. The other, one reason it's a strange worm is it's sometimes it forms free living males and females species on the ground, ultimately go back to infecting anyway. This stage here is just a way of multiplying the number of infective larvae that are produced. So in effect, it's similar if you just think to an larvae, which then chases a host to get back into the host to mature to an adult female. It's a hookworm. But bizarre about this worm is these auto-infective larvae. So you see most of the larvae species but a very percentage of them, as they're moving down the large intestine, they change into infective larvae before they get outside the host, and they actually penetrate through the lower bowel. So it's when infected with Strongyloides, infect yourself with these autoinfective larvae, and that's a picture of the autoinfective larvae from us. So the cool thing about Strongyloides makes it unique among human parasites are the autoinfective larvae. And but just to remind you about strategy with soil-transmitted helminths, it's like hookworm and whipworm and virus. Soil-transmitted helminths, they're not effective when the stage is actually passed in the feces. They need a period of time on the soil to develop. Feces get deposited on the soil. They need the right temperature. 25 degrees centigrade is ideal. But between 20 and 28, they'll develop to infective stages. They need moisture to survive. So Strongyloides can develop very rapidly to infective stage in that direct life cycle. So in 3 days, you can get feces onto the ground with larvae, developing into infective larvae within 3 days. This picture is actually from two islands, but if you look at it, if someone defecated out here, basically would happen in a day like this because the feces would tray up and the winds would be too hot, but also they'd just dehydrate, and these larvae are very susceptible to dehydration. Someone passed feces in this area where there's overflow from some sort of drain, that would be because the temperature would be okay, it would be moist to allow the larvae to survive. So that's one of the important communities.
If you think about the other extreme of temperature, that's cold, say Central Australia in winter,
and it won't develop. So below 20 degrees centigrade, it won't actually develop.
But it won't die. It just will dormant.
We stay dormant, but it doesn't develop through fairly quickly. Why it needs feces is the developing larvae actually feeds on fecal bacteria, and if it's just sitting on the soil, it's going to have the right bacteria to feed and grow on.
Yeah.
So I think I suspect that even if feces were deposited in an area like this, maybe you can get any infective larvae because it would be too cold. Except that it depends, because sometimes in winter in there it gets up to about 20, doesn't it?
Yeah, in the middle of the day it can get still pretty warm. And
it can tolerate, they can tolerate fluctuations in temperature, and Strongyloidiasis is certainly common around Alice Springs. Let's go back to those autoinfective larvae. If just look at this persistent infection, what worms have got a limited lifespan, and Strongyloides have probably lived 5 years, but due to autoinfective larvae, it's that by the time the mother is due to die, she's probably got a host of daughters that have joined her. And that's why babies say you're infected for life unless you're adequately treated. Okay, so persistent infection is spectacular with Strongyloides. The literature is full of people that got infected 65 years ago, and all of a sudden they develop problems, strongyloides. Now, the other significant thing with autoinfective larvae, when they penetrate back to the wall of the bowel, they don't necessarily have a nice life cycle where they go back to the small intestine. They do often do a lot of wandering around, so they can go virtually through any organ in the body. So they might go through the wall of the bowel into the abdominal cavity. They might very often go up to the skin, so you actually see them coming up to the skin, and that's why you get these either allergic reaction, you get hives, or you get this condition called larva currens, which is the evidence of a larvae charging through the skin, and I'll show you a picture of that.
Because, I suppose with hookworms, you get those dermal migraines or whatever.
Yes, that's with animal hookworm. Cutaneous larval migraines. Yeah, and I'll mention that.
Yeah.
So persistent infection, signs of autoinfective larvae wandering around the body. If that's an immune response against the autoinfective larvae, but they can't effectively kill them. Numbers under control. But if people's immune system collapse and they become immunosuppressed or immunodeficient, the number of autoinfective larvae that make it back to the small intestine increases dramatically, and so start getting large numbers, and then give you disease and death. Yeah, Toby?
Is this an issue with people with diabetes? You can get sort of compromised as a result of poorly controlled disease.
It had been linked exactly with diabetes, although it's common in people with diabetes. In your area, Central Australia, the big HTLV1. Strongyloides and HTLV1 is an absolute disaster, because what happens with that is that you get hyperinflammation, but the response to strongyloides leads to a greater insular T-cell lymphoma with HTLV1. It's been recognised. The links were well established in Japan, where they've got a fair bit of HTLV1.
Yeah.
And Lloyd Einstedol's been working on it in Central Australia. We'll go on. This is a picture of larva currens. If you look at this lady, this is taken on her across a plank on her ischial area, and she's got the start of a line. There is almost a arterial line that runs across her body down towards her groin. Difference from it's a line. It's usually got some amount of sort of urticaria associated with it. It moves very quickly, so that line might just take 1 day to develop that.
That's in response to the worm tracking.
That's an autoinfective larvae. Come up to the skin.
So it moves quickly.
Yeah.
Wow.
It's a larvae. The autoinfective larvae randomly around the body. So on the skin you can see it, but you can see it going to all the other organs. Liver, they even go through the brain occasionally, kidneys, whatever. They'll just wander around. The implications in that, because if one of the things that can happen with autoinfective larvae, since they're coming out of the lumen of gut, they can carry gut bacteria with them. And so when they've got a lot of autoinfective larvae moving in their body, often with various manifestations of sepsis.
Mm.
Just differentiate that from cutaneous larval migraines. That's the one you were talking about. We have an animal hookworm that moves through the skin, and it is that belly, usually about 1 centimetre a day, 1 or 2 centimetres a day. It's a sort of papular type line. It'll wander around very slowly.
Mm-hmm.
You'll find with cutaneous larval migraines, this might appear, progress for a day, and within 24 hours it's gone, and hours later there'll be evidence that actually occurred, whereas larval migraines takes quite a while to settle down. So just to comment that larval migraines is pathognomonic of strongyloidiasis. This reduces that. Easy to see in white skin, but I think it would be quite difficult to see in black skin. Mm. It's not a macular reaction.
Mm. And what is pathognomonic?
Sorry, pathognomonic just means a sign that's occurring with that particular disease. If you see larval occurrence, you've got strongyloides. Nothing really causes it. That's probably a little bit out of place, but this is just to show the presence of strongyloides at Warrabindra, Central Queensland. I'll talk about they ran a really successful community-based control program. But see, in this, its pressures, it's a peak between 20 years to 30%. So if you imagine if nothing's done with this young cohort of, they can basically have strongyloidiasis for the rest of their life, even if they never get infected again. Mm. And again, a study from Galawinku looking at prevalence, and you'll see the line to take notice of is the black line. You can see it starting at 19% in the under 10s, again up to what, 30%, 32% in the 10s, around about 20 in the 20 to 30. So it seems to have that pattern of peaking in that.
So with the that persistent infection, I would have thought that it would just be a cumulative thing. Just because the older folk treated, or because
that's actually a good question, Joe. What happened? We're quite sure, but at Galawinku, MeWatch Health was running the medical service, and strongyloid serology is part of their adult health check. And so they found any positive cases of strongyloidiasis, they actually treated them. So it could be the prevalence is in the older age group because the cases are being treated, or be that strongyloidiasis, people with strongyloidiasis drop out of the population. I think that's probably unlikely. Strongyloidiasis the epidemiology is very strange. When in Queensland, when they did fecal surveys in kids under 16, there are prevalences of less than 10%. Now the prevalences are much higher. So it could be a disease that's actually increased rather than decreasing. So early strange questions to epidemiology, actually. clinical classification.
You're always dropping off.
Can you? Okay.
Oh yeah, yeah.
Okay. If you look at the clinical classification, this can be asymptomatic, but they're a minority. You get strongyloidiasis, and that's the type of disease you get when people are recently infected, but only in children. You can get strongyloidiasis, and that's where most of the cases occur. And you can get this really severe disease where the numbers just build up to called hyperinfection. And that is if it's associated with immunodeficiency or immunosuppression. And even in the literature, even a single dose of corticosteroids can precipitate hyperinfection. That's a note because the manual says you have to worry about, this is what I told, I couldn't access the manual, you only worry about strongyloidiasis if a person is on a chronic course of corticosteroids, but that's not actually correct. The single doses were associated with people that were having local procedures, and they gave them a dose of steroids to protect them against some allergic reaction, and then they developed strongyloidiasis after that. And with strongyloides, the numbers make a difference. So if you can keep, if you can't under control, will actually stop people from getting seriously ill. So if you're worried about people getting the hyperinfective disease, if you can reduce numbers even without curing the person, you'll actually stop them from dying from it.
Mm-hmm.
Strongyloidiasis, people with that mainly present with diarrhea and protein losing enteropathy, so they deal with a lot of protein leaking into the small intestine. A nice study done in Darwin identified that kids with strongyloidiasis had a much higher likelihood of having hypocalcemia.
Gav, your audio is falling away again.
How's that?
It's a little bit quiet. If you go to that audio tab and maybe you take off that automatic adjustment.
Okay.
It is just under the video. So if you look where the participant names are, you'll see the little tab which says audio. If you click on that.
Yeah.
Yeah. Yeah, good.
Okay. That open. It tends to slide back for some bizarre reason.
Yeah, no, that's good. Thanks.
It's okay.
Yeah.
Yeah. So okay. I think with strongyloidiasis, you got diarrhea with basically with low serum is the key.
Sort of fading off again.
Yeah, I haven't got control of it. Hang on. It can off.
Yeah.
Well, again, but
Okay.
it's gone back up.
Mm.
So with low serum potassium is the thing to look out for.
Mm.
It's in age. You can see stacks of larvae in feces. If you want to diagnose acute strongyloidiasis, it's quite easy. You just look at the feces for larvae. The people can see it on direct microscopy. I would think if you people in indigenous communities, children get viral failure to thrive, just looking at the feces for strongyloides, you've got a fairly good chance of diagnosing acute strongyloidiasis.
At what ages would you, what would you consider sort of a key?
It's on the first infection. So most of the cases in the literature with acute strongyloidiasis are under 10. However, there are cases written up of adults with acute strongyloidiasis as well. And even a doctor presented and from Kuranda, she developed acute strongyloidiasis when she got infected from an Aboriginal community. Have chronic strongyloidiasis, and the way to think is numbers of worms that are sort of well controlled by the immune system, but the system can't eradicate them. So sit there, mother worms sit there, and the daughter will arrive, and then the load keeps on going on. And they do Europeans. The people with chronic strongyloidiasis have about 10% of them have skin lesions. They have of hives or urticaria. People have that larynx as well. Often have abdominal pain, which is mainly epigastric, and a high proportion have episodic diarrhea. So the abdomen and the episodic diarrhea are pretty non-specific. Getting urticaria, episodes of urticaria that come and go, might last a couple of days and then they're gone again. People usually don't associate that with worms. People are alert to it. That's something that you would pick up in dark-skinned people, I think. Larvins might be very hard to pick up, but the urticaria shouldn't be. Strongyloidiasis have low number of larvae in the feces, and diagnosis is it's hard to find larvae in the feces, and this is usually based on serology. The disease is hyperinfection, and this is a condition where the adults in the small intestine have risen quite dramatically, and there's a lot of infective larvae charging through the body. And the infective larvae coming out of the gut are dragging gut bacteria with them. So when someone's got hyperinfection, one usually thinks of it because they're presenting with bacteria. They present with pneumonia or septicemia or meningitis. It's usually due to bacteria that come out of the gut. So it might be E. coli or Klebsiella or Streptococcus bovis or something like that. They've got gut signs because they've got a lot of gut pathology going on, so they might be vomiting and they've got diarrhea. And then a proportion of them have signs of poor involvement either with pneumonia or bronchitis. And look at the sputum. It's not common to find autoinfective larvae in the sputum. And also look at the feces. You usually find large number of larvae in the feces as well. Difficult disease to diagnose because people are thinking of it because, you know, if it's someone that comes in with septicemia, you don't think it's due to worms. You should think of it in groups with high prevalence of strongyloidiasis. And you can get just bronchopneumonia like that. Here's a section from a post-mortem with, here's a huge section through a lung, and that area is an alveolus, but see it's full of, this one's full of protein, and this one's got blood in it. And under high power you can see it through a larvae there. And there is a pulmonary macrophage trying to attack the larvae. Cells are red blood cells. So hemolysis with severe strongyloidiasis is not an uncommon sign because there's sort of pathology going on. And the clues in indigenous communities that you might have a person that's infected with strongyloidiasis, if they keep coming in from the community with recurrent sepsis. Interesting case was written up for the area. Aboriginal guy who had 10 episodes of meningitis, an episode of Escherichia coli, septicemia, and dialysis, the underlying cause of it. So, treat the bacterial infection, bring it under control, and then forget to look for strongyloidiasis. So someone gets hyperinfection, they're in a serious condition. The case fatality rate's very high. It's up in the 90s if it's not dosed and treated properly. Most cases are immunodeficient or immunosuppressed, and in the literature, about 60% of the cases are due to corticosteroids or to chemotherapy. One of the messages is be very about giving steroids to high-risk groups. So be careful about giving steroids to abnormal and remote communities, because you've probably got about a 20% chance of them being infected with strongyloides.
So, did you, say if you had someone who came in with septicemia, would you suggest it'd be an approach to take serology as well?
Oh, yeah. So if I had someone come in with septicemia that I diagnosed strongyloides, I'd look at the feces, I would look at sputum for active larvae, and I'd take serum for serology as well. Because it's relative. Like strategy, the strategy for managing somebody with steroids, particularly, say an Aboriginal person, is don't not give, if it's a good intention, either strongyloides, or people just give steroids and treat for strongyloides, or even better is to treat, give them a dose of ivermectin and test for strongyloides at the same time. And strongyloides, then you can treat them properly. So probably using a treat and test strategy is the best way to manage it.
How easy is it to get the serology done? Is it one of the stock standard tests?
Yeah, it is. Yeah, it's improved dramatically, so it's not complicated getting it done.
Cost, do you know?
It's probably in the region of about $30. Yeah. Dialysis. Only the tests for strongyloides are specialised in the realm of intestinal nematode tests. Direct microscopy, you'll be able to pick up if there's a lot, you'll see larvae if there's a lot of larvae there. So, in acute strongyloiditis or hyperinfection, you might be able to see larvae in the laboratory. For chronic infection, it's hard to see larvae under direct microscopy, so they use a thing called an agar plate test. What they do is that they get an agar plate, It's nutrient deficient agar, so it hasn't got nutrients in it. And put feces in the middle of the agar plate. And if there's Strongyloidiasis larvae in there, they feed on the bacteria and then they actually migrate out across the plate. Sample here. As you'll see, as it migrates, it drags bacteria with it, so you can see a line. In the laboratory, they examine that under the scope and identify the larvae of Strongyloides. The other, that's a very specialised test. The agar plate test is very specialised. Only, and you have to ask laboratories to do it, and some labs won't actually do it. The best for, in general, and particularly for chronic strongyloidiasis, is Strongyloides serology. It'd be negative for the acute disease because it hasn't been long enough to develop antibodies. They may take 3 months. It should be positive in chronic disease and in hyperinfection.
Immunosuppressed patients. Is that
it's probably going to be okay. But it seems that the T-cell immunosuppression, I think, that lets Strongyloides get out of control.
Mm-hmm.
Somebody was immunosuppressed, I'd do serology, but also look at feces as well.
Mm-hmm.
Treat is ivermectin, and the standard dose rate, 200 milligrams per kilogram. And even one dose by itself will cure probably about 70% of cases. If you 2 doses, you bump the cure rate up to probably 95% or higher. There's no question ivermectin is the best treatment. There's a bit of evidence about the details of the treatment regimes, about how many doses should you use. That's where the disagreement comes in, but I'll talk a bit about that.
Mm.
So, yes, is ivermectin. It's a drug with minimal side effects. Choice is albendazole. And the reason for that is that ivermectin in Australia is not licensed for use in pregnancy, and it's not licensed for use in children 5 years, actually. I've got 10 kilograms there. That's the WHO recommendation for globally, but in it's 5 years. So to comply with the people who treat children with albendazole, ivermectin in pregnancy, there's quite a number of papers written now about using ivermectin in pregnancy, and there's no problem. It just isn't licensed. Some in Australia now, particularly in Aboriginal communities, are using a combined treatment and combined with an albendazole. And one of the reasons for that is that there's might protect ivermectin against development of resistance. Actually a recommended strategy, but I know it is being used. One of the problems with ivermectin is absorption is variable. Most people absorb it well. Some people see difficulty and they don't absorb ivermectin. But that's know about why is. You can measure serum ivermectin. It's usually done in scientific services with Queensland Health, but I don't know if they're doing it now. Here's an example of a patient who didn't oral ivermectin, and so you can see this is their level. So this patient had Strongyloides, quite a heavy infection. They were treating them for Strongyloides, but it wouldn't decrease. And you can see when they gave oral ivermectin, they gave it rectally because the person was having difficulty taking oral fluid. Rectally, it didn't make any difference, and you can see it started off at a low level, so he was getting very poor absorption, and they used a veterinary product under permission and gave it subcutaneously, and you can see they got quite good levels cutaneous. But people, for some reason, who don't absorb ivermectin, and it's not really quite known why it is. So if you get a treatment failure, it may not be the worm resistant to ivermectin, it might be the person is not absorbing it effectively. Ivermectin acts against the adults, it kills the adult parasitic female, but it also kills those autoinfective larvae. So that's why it's the better treatment. Bendazole just kills the adult female. It doesn't kill the autoinfective larvae. So with albendazole, you could kill the adults, but you might have autoinfective larvae wandering around the body that when, after a period of time, come back down to the small intestine to establish. And the same thing probably happens with some people treated with ivermectin.
So is there a thought that with multiple dose treatment that you kill the larvae that have hatched subsequently?
Yeah, so that's what the sort of the question is about. So okay, we know we can kill adults fairly effectively. We know with ivermectin we can kill some of the filariform larvae. Obvious that some of them don't. So what you're trying to do when you retreat, you're trying to get those filariform autoinfective larvae that miss out on didn't die with the ivermectin. You're going to kill them when they come down to the small intestine as adults.
Mm-hmm.
If we look at regimes, if you look at the regimes, it's to read that 2 treatments are better than 1. Some people say retreat at 7 days. I'll say treat a month after the first dose, and some people say give 3 doses. But it's haven't really got good evidence to say which is the best treatment regime.
Is it how long the eggs take to develop?
Rapidly. Those will develop in 24 hours. So inside the body, they'd lay, the egg would then come out into the lumen, and with 24 hours you should get those larvae out there in the lumen of the small intestine. If we look at, I'll just go back, with hyperinfection. So what we're trying to do with hyperinfection, we're trying to kill the high numbers of adults in the gut and also the vast number of autoinfective larvae. There were some Japanese studies that showed that you could have thousands of adults spread through the intestine, and you could have millions of autoinfective larvae wandering around the body. So kill those, but then you've also got to manage the abnormal physiological changes that are going, because you've got sepsis and you've got problems with the gut. So complicating. When people have hyperinfection, they give multiple doses of ivermectin. Some gives ivermectin every day for 2 weeks, but other regimes, particularly one used in the Northern Territory, about 7 or 8 doses spread over 2 weeks. But there's no trials on how to treat infection. So people are just sort of empirically. the note with treatment is you need to monitor people because you're worried that you have killed all the autoinfective larvae and that you might get rid of the adults from the small intestine, but the autoinfective larvae can come back down to the small intestine and restart the infection. You are sure that people are adequately treated. You can use the regimes, but you monitor how people are going by using the Strongyloidiasis serology and do it monthly for about 2 years until it goes negative.
So how does it take for serology to go negative?
Usually 6 months. In the vast majority of cases, you'll have people their negative serology 6 months after the treatment. If you're, it's probably recommended that you treat them again.
Mm-hmm.
Through workshops, this is sort of what we've developed, and I suppose the thing to note is that you're doing follow-up serology. Eosinophil count is not that much, but do follow-up serology at 6 months and retreat. And then it says retreat with 3 doses of ivermectin apart, but that's it's arguable. Mm-hmm. So, my message is that if you're someone who's positive for strongyloides, you treat them, do an ELISA at 6 months. If it's negative, you can say, okay, the infection's gone. If it's positive, retreat them again, and then to them again 6 months later to see what's going on.
Mm.
Ivermectin is quite a safe drug. It has licensing restrictions in Australia, unfortunately. It is in breast milk, but it's very low concentrations. And those papers I've given there calculated that, and if a mother given a standard dose of ivermectin, strongyloides, and you didn't treat it during pregnancy, but immediately after birth, you treat the infant would get something like 1% of the dosage in the milk, so it's pretty safe. If necessary, if a pregnant woman is in strife from ivermectin, you could use albendazole, or you could use ivermectin, but it's just not registered for use. The other is that if you get somebody with filariasis, and so you're mainly talking here about people that have come in from overseas, if they've filariasis and you treat them with ivermectin, they'll get a reaction. So they'll get the ivermectin and produce this reaction with worms. You get headache, malaise. If people come from West Africa, if they've got lower, so that's pretty specialised type of stuff. And for put in their recommendation for what to do if they have a person with positive serology and the person's a refugee from West Africa, they are testing for lower. Been lower, but it's very uncommon. So, strongyloidiasis in Australia, the big group is Indigenous residents of rural and remote Aboriginal communities. It occurs in Torres Strait Islanders, but there's no data on Torres Strait Islanders. A colleague working in the Torres Strait, he said he got positive serology in Torres Strait, but it actually hasn't been documented. Well, it seems as though about 15% of the community is live affected. It's also been detected in people who work in these communities. Nurses are a common victim of strongyloidiasis. Also reported in doctors and other people who work in the communities, and even reported in grade nomads visiting communities. It's in refuge from Southeast Asia and from Africa, probably around about less than 5%. Personnel who served in high-risk areas, the Vietnam vets, they're getting to about my age, and they've got about 1% still. And also we detected it in Ramsey personnel in the Solomon Islands. Then you get occasional cases of people coming from Europe, where Island, for example, old Italians, every day they turn up with strongyloidiasis and they're beyond treatment and it's out of control. In Queensland, and this is just from fecal surveys. So you see from this, your strongyloides detected at Arakoon, but interestingly, you see a fairly high collection at Mornington Island. If you do serology in a community, you'll find a much higher percentage, but this is just fecal specimens submitted. And there's only whipworm, basically whipworm, and the CRH, the roundworm's gone, except it spills over from Papua New Guinea, still occurs. So that helminths are getting a real hammering, actually. This map was constructed by Jenny Shield from laboratory reports, and so we could get laboratory records from various places over Australia. And when you mapped it out, we thought it was a tropical disease, but to surprise, we actually find that it's quite common around Central Australia. It's also common in northern Australia as well. Even down.
There's quite a lot of movement, like APY land up to right around Alice.
Yep.
Over into WA as well.
And the other curious collection is it's all Indigenous people. The other curious collection is in northern New South Wales. It seems to be reasonably common around the Forster area. I know what's gone on in your area, Rita.
Yeah.
It'd be interesting to have a look. People probably don't think about it, but I'm sure if you had a look, they might find that there's people moved down from up north that are carrying it. If you want to mission, you basically got to break the cycle of the parasite and stop people from getting infected, and use this integrated control where you use drugs to kill the worms. I've been killing adult worms and autoinfective larvae. Sure, people don't put feces on the ground. Around hostile to survival, you're making sure you haven't got leaking drains and running taps and stuff like that. And even wearing shoes can help larvae from getting in. The question of drugs, if you've got a high prevalence in communities, it might be better to treat everyone. But if there are particular groups, it could be worthwhile targeting those groups. Communities, Warrior community in central Queensland, and did a control program and used a multiple intervention approach. So they used a treat and test program. So they went around to all the community members and offered them ivermectin, took blood serology. If someone was positive, they came back and gave them a second dose. If they had negative serology, they said, well, they were negative, and single dose of ivermectin didn't. they also went house to house and checked for leaking toilets, leaking stuff like that, and then a health promotion program. So promoted sort of getting to wear shoes, and at the school they even had a shoe barometer at the school where they plotted the number of kids wearing shoes to school. Mm. With their treatment program, they had a cure rate of 80% at 6 months, which was also the interesting thing. They also looked at cases who had been negative on the first screen. They looked at them 6 months later to see if they'd gone positive, and them had. So it looked as though that actually stopped transmission in the community. Up in the Northern Territory, an experimental study that had promotion with doses of ivermectin using the same sort of approach. Dosing everybody with the first dose of ivermectin and coming and giving a second dose within a month if a person was positive. So that in that committee they came back and tested prevalence over the course of 18 months. And the prevalence went from 21% to start with and it down to 2% and stayed there. I ran the program. So yeah, at the Winku, their first level percent, they treated the body, came back, treated the positives at the second dose of ivermectin, and then they looked at it 6 and then at 12, and at a level which also indicated that they'd broken the transmission cycle. So it looks like level can actually break this, potentially get rid of this parasite, and there's more work going on about to look at the strategy. Some Aboriginal medical services include serology as part of their adult health check, and Watch in Arnhem Land does that as a routine. And that's it.
That was really good.
Yeah, it was great.
Rhea, did you have any questions that you asked?
I was just wondering how it was interesting about the ivermectin being all right in pregnancy. I was does Strongyloidiasis, do they ever go into the placenta?
No, it hasn't been reported in humans, but I do know there was one case in a great zoo. I think it was a chimpanzee that had a transplantal infection. It doesn't seem it could occur, with autoinfective larvae wandering around, but it's as though it's never reported in humans.
Okay. So in pregnancy, there it is a bit decreased anyway, isn't it? So.
Yeah, that's right.
Hmm.
Hey, Rhea, have you seen people that get recurrent urticaria in Aboriginal communities?
In Central Australia, but as you said, it is quite hard to see that occurrence on black skin.
Yeah.
But because I suppose Central is generalised.
Yeah.
Around. There were those quite wet years in 2010, but I haven't actually seen any.
Yeah, one of the questions about strongyloides in Aboriginal people is, there's certainly people that die from the disease, and there's certainly acute cases, but there's question about the chronic disease, more Aboriginal people compared to, Europeans.
In that HTLV1 too, because where's Lloyd? He's come back with Alice recently, I think.
There's consultant ID.
Yeah, Lloyd actually did some nice people with Strongyloidiasis and quite a number of them at HTLV1. And it was terrible. That was in the early 2000s. Hopefully it's improved. But I know he's identified it as quite a significant issue.
We had some, like, they don't really test people for it because there's nothing. HTLV1, because it's a small group, and plus people, they don't have treatment for it, is there?
No.
It's obviously different, but we had a couple of women, like if a woman got it, that you can give it to the baby through the breast milk. So
yes.
They were talking about like do you breastfeed or not breastfeed, and any. I think no.
Yeah. The other to be aware of with, it seems people that have got HTLV1 are much harder to cure as well.
Okay.
From
Oh, that's really good.
You'll have to have a look at it if you have some Aboriginal patients.
Well, I'm so in Alice for about a month, but when I come back here, I'll be looking, because like it is really. I don't know Mavis is that particularly interested as a group, as many places. So I think if there's some interest, I might get a job with them.
Oh, good.
Yeah.
Okay. Thanks heaps for that. That was really good.
Okay.
It was like special. It was like we were the one